How was the cultural evening last night? Did you enjoy? Okay. So welcome back to the scientific sessions. And now, ladies and gentlemen, we have our next speaker, Dr. Raul Ayuso.
I would like to difference the needs of the different type of patients, because usually we have to rehabilitate different profiles of patients, and probably this patient doesn't need the same than this one, and totally different than this one. Then I would like to make a special effort in trying to reduce or avoid complications with a correct study and planification and a correct dental planning before doing every type of procedure. In some cases, we have fractures, complications of this type of complications, and probably it happens because we don't respect the correct thickness of the materials. In other cases, we have a lot of thickness of the materials, and it has also different complications like hygienic difficulties. Then, the most important thing before doing an implant treatment, I think, is the correct planning and study of every case. Then we can measure all the occlusal interarch space. I would like to make attention to this paper by Abraham and Cos, who accepted only totally edentulous patients, and they measured the distance between, in an optimal dental WhatsApp, they did a digital planning surgery for the correction position of the implants. And they measured in the CBCTs the distance between the alveolar process where they could place the optimal implant and the optimal position of the neck of the prosthetic teeth. Then they could measure this distance and this angle. In the cases with low resorption, this distance is lower, and we have to put the neck of the teeth very near to the implant position. On the other hand, when we have a patient with more atrophia, this distance is longer and the angle is very low. And then they added the data if patient needs or not a buccal coverage with resin for the optimal profile of the soft tissues of the facial inferior part. Then they divided the patients between, if they only need to restore the Sadowski in 2014 determined the mandibular optimal thickness for the needles of the different materials, and in 1915 did the same for the upper jaw in maxillary restoration. Based in the evidence at this moment, he determined that the optimal thickness for a metal ceramic design was a minimum of 7 millimeters. And for a metal resin design, from 11 to 15 millimeters. It's logical because this type of patient usually doesn't have a very important resorption of the alveolar process. And this type of patients have more resorption. That's a clinical case where that I had to restore, and in the first session I knew that the occlusal plane of the inferior arc was very near to the upper alveolar process, where I prefer to choose fixed restoration or removable restoration depending on the available volume to restore. Thank you very much.
Ladies and gentlemen, can we have a big round of applause? Thank you so much, sir. And now we come to our next lecture, which is on non-grafting solution for atrophic ridges, expansion of narrow ridges, by Dr. Iván Ortiz García.
Today we are going to talk about bone expansion. Bone expansion is an advanced surgical technique that allows us to insert implants in those situations in which we don't have enough money, enough bone in the bucopalatal direction. Okay, bone resorption difficult us to insert the implant in a correct prosthetic position. So in these cases, we have to use more traumatic and sophisticated techniques such as bone graft or guide bone regeneration. These techniques have more possible complications. Okay, when we want to insert implants, we must to take care when two important points: the quality of bone and the quantity of bone. The quality of bone is important in bone expansion because we separate the two corticals, the two plates, by breaking the bridge in the medullary bone. So if we don't have enough medullary bone or the medullary bone is too hard, this technique is more difficult. So we know that we have 4 types of bone, from 1 to 4. The first have a very hard cortical bone and very less medullary bone, and the last one have a big amount of medullary bone. So this technique was described as first to be realized in the upper maxilla, because well, if we want to insert implants, it's very important that around the implant we must have 1 or better 2 millimeters around the implant, and in these 2 millimeters we must have medullary bone, because if it's not medullary bone and only is cortical bone between the implant, around the implant, this bone is going to be restored until it's fine medullary bone. So we need 2 millimeters around the implant of medullary and cortical bone. But these techniques have limitations. If the technique consists in separating the two corticals, the two plates, if it's not one of the corticals, we can't make this technique. And if we don't have medulla between the corticals, this technique can be also developed. So in these cases, we must use more complicated techniques such bone graft. But if we have medullary bone between the two corticals, we can develop this technique. Well, a little bit of history. Osborne was the first person who used Jesus to separate the two corticals, but he filled the gap between the two corticals, but he don't insert implants. Okay, Nedwin was the first who insert the implants at the same time he separate the two corticals. Well, the flap, if we tear the periodontium, we are going to section the 80% of the arterial vascularization and 100% of venous drainage. So if we can, we must make very soft or very not traumatic incisions. Okay, and then we are going to make the corticotomy. And the corticotomy we can make with one. Is the fact that we have to make with this type of instrument is to break the bridge between the medullary bone, but so we get elasticity to move the buccal plate. Where we eliminate the trabecular trace, and then we use the expander sequentially until it's important to say that when we made the corticotomy, we must be very deep, and we must get the length of the implant we want to insert. So, because this fact is important that we although we don't have enough bone in the bucopalatal direction, we need enough bone in the apicocoronal direction. Okay, sequentially, and we insert the implant. Right? Okay, we use this instrument, the expansor, the screw expansor, pressing and rotating. And if we notice that we have resistance, we can use the pilot drill before continuing using the expander. When we insert the expansor, we must to wait 20 or 30 seconds to consolidate the microfractures that we have done in the medullary bone. And when we get the last expander, we must to insert our implant. If we are going to continue inserting implant with this technique, but avoid the collapse of the bone. Okay, sometimes it can make a fracture when we make this technique in the vestibular plate, but it's not important if don't compromise the primary stability of the implant. So, important consideration. Patients, we have to take care. We need to insert the implants until the length of the implant we want to insert, a good corticotomy, a deep corticotomy, use the sequence of expansors correctly, and the design of the implant is very important. Tapered implants allow us to realize this technique more safely. In the upper maxilla, in which we are going to insert 3 implants in this area that don't have enough bone in the bucopalatal situation, and then we use the piezoelectric scalpel very deep, and then we insert our expanders until we get the diameter of the implant we want to insert, and then we insert our implants, and we fill the gap with biomaterial. So there are a lot of authors that say us that this technique is a predictable technique. If we have enough experience achieving the same rate success that the conventional technique. So, to summarize, gap expansion is a relatively non-invasive technique and safe if there is sufficient surgical experience in the system by the professional. And we achieve survival rates, the same or similar survival or success rates than conventional implant insertion techniques. And that's all. Thank you very much for your.
Thank you, sir. That was a very nice lecture. I request Dr. Sumit Singh Fukela to kindly honor Dr. Garcia with a memento of the university and a certificate of appreciation, please. Thank you, sir. And now we come on to the last lecture of the first scientific session for today, and that's immediate post-extraction implants by Dr. Eugenio Velasco Ortega.
My lecture is about post-extraction implant in fresh socket. It's a technical very, very, very important today. Two extraction may modify the width and the height of the residual ridge. And it's important the preservation of this fresh socket because the implant position is important for the rehabilitation of the patient. There are many studies in animal experimental about the insertion of implant in fresh socket. In all experiments, there are two important findings. There are research about buccal and lingual table. More important in buccal table. There are many studies about implant in post-extraction. This is a classical study based by the group of Daniele Botticelli. It's an important classical study because they are during 5 years. 5 years. No implant was lost, and bone leaving of the implant were maintained or improved. What is the secret of this study? All subjects were enrolled in a supervised oral hygiene program. They are not secret. Their maintaining program is a 4-step of implant dentistry. The first step is the diagnosis, the second step is surgery, the third step is prosthodontic, and the fourth step is maintenance. When I have a patient in our dental clinic and we diagnose the patient prior to surgery is treated with antibiotic. We made a traumatic extraction, and we have a systematized protocol with insertion of drill and insertion of implants. And after, we can retire the backbone of transfer, and we can the crown. For the success of implant post-extraction, is essential the selection of adequate implant system. Implant system is macroscopic design and microscopic design. This study demonstrates that both groups of fresh socket treated with biomaterial and guide bone regeneration, the mucoperiosteial flap gave significantly more negative results than of the flapless procedure. Is a recommendation for flapless technique. But when I insert an implant in a fresh socket, in this case, there are a destruction of bone because they are before a granuloma apical or an infection, and it's necessary, in this case, the use of bone substitute. The circumferential defect, the clinical must select if use biomaterial or no use biomaterial. This course, this paper with Ugo Cobani, the University of Pisa, suggests that in fresh socket with circumferential defect, it's not necessary always guide bone regeneration of use of bone substitute. But it's important for the clinical a comprehensive assessment prior to extraction. Prior to extraction include dental, periodontal, patient, and combined computer tomography. Today, this technique helps to doctor to transversal. Imagine you can see the table, lingual table, vestibular table, and we can select the ideal position of the implant and a diagnosis of bone around the tooth, in this case with a affected vestibular table. We can see the process of the technique of extraction in a periodontal tube. It's necessary always, in this case, open the mucosa because they are an important bone defect. In this case, there are two approaches. a immediate implant insertion or a regeneration before and after implant insertion. In this case, we realize a immediate implant insertion with drilling, careful, is the neo-alveolar, new circle, drilling more than 4 millimeters beyond the root apex because it's necessary a high stability. We insert the implant with a stability, with primary stability. We place a bone substitute, and after 8 or 9 months, radiography of immediate implant, impression, provisional prosthetic, immediate loaded, and definitive square prosthesis after 3 months. Thank you so much. If you have any question after, it's possible, the rotary.
That we can delay the implant placement for viewers.
Entonces, si pueden esperar unas horas en el alveolo post extracción, se pueden esperar unas horas antes de poner el implante.
Wait. You wait 4 hours.
Suppose the patient.
You go to buy the implant.
Suppose the patient was not ready for the implant that time, but after going home or after that he realized that he want to get it implanted. That situation.
I'm introducing the guest speaker, Dr. Carlos Arranz.
My lecture will be about the lateral approach for the sinus lift, and I will make a review of the complications of this technique, as I think it is likely the most interesting point for everyone. I have named it Sinus Lift Approach, Effectivity versus Complications. Lateral approach sinus lift is a surgical technique widely supported by the literature in terms of effectivity and prediction. Despite this fact, we should not balanize this surgical technique because it is an invasive procedure by which we are going to get a sterile cavity and put it in contact with a contaminated environment like the oral cavity. That's why it is very important to keep sterilized during the whole surgical process. On the other hand, it is a surgical technique that could lead to intraoperative and postoperative complications that we must know and be able to treat. Moreover, we need to know the risk this technique might cause. The surgical technique is not the aim of this presentation, and it is widely known. I'm only going to comment that there is a quite controversy with some issues of the technique, like incision types, the use of rotatory or piezoelectric material, lateral windows size, the performance of the anastomomy or ostectomy with the removal or not of the bone cover, the use of this bone cover as an autograft bone, the filling material that we are going to place inside the cavity, alloplastic versus autograft versus biomaterials versus mixtures. The use of the membrane in the anterior wall once we have finished the sinus lift or not. The immediate or delayed placement of dental implant depending on the patient's residual basal bone. Types of suture that we can use. To conclude, we can make a summary saying that sinus lift is a predictable and reliable surgical technique. We need to know the complication that this technique can entail as well as how to solve them. Moreover, maxillary region anatomic knowledge and its preoperative study with a CT is essential to prevent these risks. Thank you for your kind attention.
And now we come to our next lecture. Let me introduce Dr. Nuno Garrido. Dr. Garrido is a Bachelor of Dentistry from the University of Coimbra.
Expect 100% creativity. Okay? So, this presentation will be divided in 4 chapters, some biological principles, some fundamentals of the technique, the selection of the technique, and then a take-home message of all this. Starting by the basics, like you all know, I've been said here before a lot of times, every time we do an extraction, something happens. And what happens is the bone remodulates. It remodulates in such a way that we lose on the first year around 1/4 of the volume of our crest, 25%. And if you wait even longer, we will lose between 40 to 60% of the volume. Well, if we said here before that our implants have to be placed according to the right position of our crowns, guided by our prosthesis, this will give us 2 problems. Either we put our implants on the wrong place, guided by the anatomy, or we put our implants on the right place and we leave them partially out. And this is a problem. If we decided to put our implants guided by the prosthesis, but we don't have enough bone, we'll end up with situations like this, like this, like this. Or maybe those cases that we just leave a little bit of the implant exposed and say, this is okay, just a tiny bit of titanium exposed. The thing is, titanium has a treatment, it's rough, has a rough surface. This rough surface, it's there for a reason. It's there so the osteogenic cells, so the osteoblasts, can grip on there, can go there inside those little holes, create those tags, and proliferate on it. So what do you think will happen if a bacteria gets there? The same thing. It will start colonizing all the surface, and it will end up with periodontitis. So every time you next time you put an implant and leave that little bit of implants outside of your bone, know that that little bit of bone of implants will probably be in contact with your periodontitis sulcus, and there will be bacteria in there. And that bacteria will kill your implant. You will lose that implant. So no, it's not okay to leave just a little bit outside. So, what do we do to prevent that to happen? We do the GBR technique, the guided bone regeneration technique, which you've all heard about it. So basically, what it does is it's a technique that allows us to recuperate, to recover the amount of bone that you've lost on that defect. So imagine you have the typical defect, a little hollow on your bone, and the first thing the body tries to do is to close that really fast. That's a way of bacteria to get in. So if we leave it open, we'll get infections. So the body has to find a way of quickly close that. So what's the quickest way to close that? Will be with epithelium, with connective tissue, and that will just get inside the defect. So what will happen is something like this. Instead of having a grafted area, instead of having everything filled with bone, we'll have everything filled with tissue, because tissue grows faster than bone. So a GBR technique is any technique that will prevent that from happening. Any membrane, any barrier that you can place there and will not allow that rapid growth tissues to get inside that defect. And by not getting there, allows the slow growing cells of the bone to occupy that volume and all those angiogenic cells to be able to create that bone. Okay? And that's the GBR. So, no, it does not matter what you put in there. There is no miracle powder that you put in there and it will create bone. A GBR technique cannot be done just with biomaterial and covered with periosteum. No, that's not the best membrane. The GBR technique only exists if you use a barrier. The technique itself is described by the use of a barrier. So you always have to use that membrane. So first rule of thumb that I want you to get out here is, yes, I will always have to use a membrane. I might not use biomaterial, I might not use bone graft, but yes, I will always have to use a membrane. Imagine these 2 cases, okay? We have these 2 situations, some kind of defects. Here we have a deficiency, here we have a fenestration. We'll see a little bit more about that later. This one will work, this one will not work. Why? In order to know in which cases we'll be able to do a technique, a regeneration technique that will have 100% predictable results, and another one that Well, it might work or it might not work. In order to know that, you have to know which defects you have. Now, still on the classification of defects, this is not important once you start the surgery. No, you do not start a surgery, you do not look at your bone and you do not say, oh look, I have a zero-wall defect. No. You know this before you start. And that's, again, what makes your generation predictable. If you know what kind of defect you will have once you place the implant, you will know if you want to place the implant or not. Okay? Because you might decide that placing that implant and doing the bone graft at the same time will be a non-predictable bone graft. And if it's non-predictable, I don't want to take the chance of my graft doesn't goes exactly as I want and it just goes 50% of it and then I have an exposed implant. So when I'm in doubt, when I don't know if a bone graft will work or not, I will never place my implant. Never. So, non-predictable defects, which one will be? It will be exactly the opposite. Imagine a situation like this. This is very typical. We see our patient, we plan it, we put an implant, we say, well, just a tiny bit defect, I'm okay with this. So I'll just put my implant, all the normal sequence of drillings, I do my graft, I put my member, I stabilize it, I suture everything with primary closure, no tension, and I don't know what will happen. This is a zero-wall defect. I should never, ever have done this. This is wrong, okay? I have no way of predicting exactly the amount of bone I will create around this implant. So, the most likely thing to happen here is I don't have 100% coverage of the surface of the implant that I generated. I just have maybe 80%, 70%, but that 20 or 30% that I'm missing will be an exposed implant on the sulcus. So it will be a compromised implant and it will be a lost implant. Okay? What I want to do is a technique much safer, much more predictable, and the patient has to accept that. If he's in a hurry, it's his problem, not mine. This is what I'm going to do. I'm going to do what's predictable. So, I do my extraction, I do my grafting, and then, after 2 to 3 months after, I place my implant with enough bone around it. 100% predictable technique. So this will be it. This is the planning of the case. We already knew the defect will be finding. We clean everything, take out the granulation tissue, place our membrane, more thick and more stable membrane than the usual collagen membrane. We close everything, and once we go back, after 6 months, okay, we already see a totally different situation, much better, much more positive situation than we had before. We place our implant, plan it, and again, totally predictable with enough connective tissue around it. Very nice tissue, I mean. Case 4, last case. This case I placed here for a reason. This is the type 1 fenestration. It's a 2-wall anticipated defect, so it will be a totally predictable defect, and I'm doing a postponed implant. Okay? Why? When in doubt, when I'm not sure of the technique I'm going to use, of the technique is going to work exactly as I want it or not, because I have a thin biotype, or just because the patient is very demanding and I'm afraid I cannot achieve what I want to achieve, I can always do a deferred technique. I can always, even if it's a predictable defect, I can do a postponed technique. If I want to be absolutely sure, and I can do that. So in this case, what I did was, I make the extraction, I make the graft, I waited, and then later, I placed my implant and I have a totally predictable result. In the most common technique, what we do is we use a resolver membrane, we support it by a graft material, which gives us a low risk of membrane exposure and has a predictable healing and fewer surgical interventions. How do we decide one or the other technique? The use of a simultaneous versus a deferred technique depends on the clinical circumstances and the morphology of the bone defect like we've seen. Okay? This is what I have to tell you. I hope you...
And now we move on to our next lecture, which is on the importance of periodontium in the implant patient by Dr. Juan Amaro. Dr. Amaro is a Bachelor of Dentistry from the University Complutense of Madrid, a specialist in gerontology, Masters in Periodontics and Implantology.
It has been changing, and in the first decade of my professional practice, 80% of my practice was periosurgery, plastic surgery, and also regeneration, and only a little of implants. By little by little, it has been changing in the second decade of my life. And nowadays, implant therapy has become more and more relevant in my office. It's almost the 50% of the practice that I do in my office. Moreover, this increase on the implant practice has become followed by several techniques and also by several complications. And to be honest, some complications we don't know how to treat properly. So nowadays I have a mix of implant teeth with several pathologies, and I have to rethink all my protocols in order to cover these complications. Implants are the new revelation in all clinic, that sometimes the implants are forced us to act in and not in the correct way. We are living at the vicious increase of the implant therapy. I don't know if it was Eugenio said that more than 5 million of implants are used, more than 5 million of implants. Wow, it's a crazy number. Clinical evidence have pushed the implants into the first choice to rehabilitate full or partial dental patient. Based in my opinion, on justified principles. The first principle is the proactive strategic extraction of the teeth in order to prevent bone loss. But all we know that extraction is not a way to prevent the bone loss, because during the healing is a natural process that has a high biological cost. More than 60% of the bone, of the horizontal bone, is lost during the healing, and more than 20% of the vertical bone is lost during the healing. Also, socket preservation is a very useful procedure that can limit but not avoid the changes in the alveolar right. Vertical and horizontal changes are minor but still appreciable. And at least, sorry, Eugenio, immediate implants don't avoid the bone resorption. The changes during the first month after the implant placement in the buccal aspect are dramatic. More than 56% of the implants lost totally the bone wall, the vestibular bone wall. So maybe in the future, all of us will have a lot of implants with the apex out of the bone in direct contact with the connective tissue. The other principle is the questionable advantage that the patients have about implants. They think that they are more predictable than teeth, they are better long-term prognosis, there's a lack of complications, better friction, better aesthetics, better for everything, but it's not true. So if we assume that these two principles are not supported enough of the papers, we must conclude that the implants should be always considered as a treatment for tooth loss. And the nightmare begins when we review the prevalence of the pathology. More than 7% of the patients will suffer mucositis, more than 50% of the implants will suffer mucositis, more than 50% of the patients will suffer periodontitis, and more than 30% of the implants is going to suffer periodontitis. So the problem is that more than the 60% of the patients will suffer one or another. So, as the commander of Apollo 13 mission said, okay, Houston, we have a big problem. Mainly because we don't know how to treat it properly. So there's some questions we have to ask ourselves. First one, are our patients commanded to have mucositis or periodontitis? How can we assess the future risk of our patient? Or how can answer our patient when they are demanding data about the durability of their treatment? For example, every day in your clinic, are the implants forever? Totally no. How long will they last? It depends on you. I don't know. For example, this case, this is my practice because I'm a periodontist. So this is the normal patient in my clinic. This is 65 years old, male, non-smoker, no medical related. The culture was normal, gingival index found 100% high bleeding improving, high plaque index, and it's a chronic periodontitis. This is the X-ray. And a little distinction, and I totally agree with Dr. Nuno. This is not a periodontitis. The first way to prevent bone loss is the correct three-dimensional position of the implant. Look this implant, look the activity. There are some bone losses that have no infection causes. So you need a perfect frame of soft and hard tissues to achieve aesthetic and stability, not only in aesthetic areas. Also, you have to manage the tissues in non-aesthetic areas to have the best framework that you want, or as you can, in order to achieve some stability of the case. Now, sometimes patients accumulate plaque, and sometimes the amount of the plaque is enough to cause pathology. And the first sign of alarm is the mucositis. Mucositis, as you know, is the presence of peri-implant site of soft tissue inflammation like swelling, bleeding, redness, and the absence of bone loss. We can make a parallel correlation between gingivitis and mucositis because experimental animal studies show that the plaque accumulation is the main cause of this pathology, and more studies like Figman show that after a very close plaque control program, almost 100% of the locations were healthy, and after 3 weeks of no oral hygiene, all the locations are gingivitis and mucositis. So plaque control is the best way to prevent and to control the mucositis and periodontitis. It's very important to be sure that you are controlling these patients because it's too easy. You only have to remove the plaque with a mechanical device. It's not enough with chlorhexidine or whatever you want. You have to remove the plaque. And because studies have shown that you can return your patient to the total health after 3 weeks of no oral hygiene. All the patients have inflammation, and after we return all the plaque control, all the patients return to normal health. So plaque control is the best way to control and to solve mucositis, but it's not only the way to control mucositis. Also, it's the best way to control and to avoid periimplantitis. This study, Costa 2012, is quite pretty because he compares 2 cohorts, maintenance group, no-maintenance group. At the end of the study, he showed that in no-maintenance group, no implant was health. And the most important data is the group of no-maintenance care had 3 times more risk for periimplantitis. So plaque control seems to be the main factor to prevent periimplantitis. And it's more important, it's over another risk factor. So, for conclusion, please give a chance to the teeth. Even the teeth are really compromised, periodontal treatment has a very good result. Prepare and classify the patient, treat the patient, and evaluate his response, and try to be sure if he is a patient with a rapid progression or a slow progression of bone loss. Motivate the patients, enroll all the patients in a very strict plaque control program, and always prepare an alternative plan, because in the future maybe this patient will lose the implants, and maybe in the future we will find a patient with no teeth, with no implant, and with no bone. So an eye for an eye, soon the whole world is going to be blind. So thank you very much.
We'll be starting with the presentations without wasting any time. It's really an honor for me to invite the first speaker for today, very well respected senior of mine, Dr. Vijay Lakshmi. Ma'am, please.
TMJ ankylosis, this is a condition in which the patient is not able to open his mouth. And the reason behind is that there is a union of the condylar head with the glenoid foot. It can be fibrous, it can be bony, or it can be both. Now, because of inability to open the mouth, what are the problems that arise? Patient is not able to chew properly, patient is not able to speak properly, oral hygiene is affected. If it is a unilateral case, then there is facial asymmetry. Bilateral case, severe retrografia is there. And because the patient doesn't look normal, doesn't speak normal, doesn't eat normal, he has psychosocial problems also. So these are the problems patients face. Now, you all must be knowing that there is a classification given by Shawnee. He has divided ankylosis into 4 types, 1, 2, 3 and 4. Depending upon what is the location of bony union and how much is the extent of the bony union. Okay. As you were telling, the treatment modalities usually that are followed are gap arthroplasty, in which we remove that union, that conilo-temporal union, that bone mass is removed. If you just remove it, leave it like that, then it provides superior reliability and greater accuracy than conventional radiographs and panoramic radiographs. There is no overlap problem, no distortion problem, and proper diagnosis and classification affect the choice of surgical procedure. Now, if you compare it with normal CT, the radiation dose is less. So, instead of going for normal CT, go for CBCT, and it is less costly also. If you go for CT, I think it will cost you around 5,000. This will cost you around 2,500. So half the cost. So the conclusion is, in Swane type 3 ankylosis, go for lateral arthroplasty, because when you do this, then the medially displaced condyle, it can be left in situ to maintain mandibular ramal height, function, and to act as a growth center in children. And CBCT plays an important role in diagnosing and planning such cases. This is one of my patients. You can appreciate the after removal of the lateral bony bridge, you can see the condylar head which can be seen, which is on the medial side, and this is a buccal fat pad that is harvested from the same approach, and then we put it on the lateral side. This is the preoperative photograph of one of my patients. These are the post-operative photographs in which we did lateral arthroplasty, and this has been published also, this research work. Thank you.
So, hello everyone. First of all, I would like to tell you that I am a bit scared standing in front of the pool of so many oral surgeons, because myself, I am an orthodontist by profession, and then I did implantology, and currently I am working as a consultant in Vedanta. So, I would be demonstrating here the role of CAD/CAM and inverse planning technique in maxillomandibular reconstruction with free fibula grafts followed by dental implants. Although the major part that I am playing is the CAD/CAM planning and followed by the prosthetic planning, but I will give you an insight into the surgical planning as well. So why do we actually need maxillomandibular reconstruction? It can be due to any bony defect which is above its critical value. So critical defects basically are the defects which do not regrow or which do not reconstruct on their own. There are numerous etiologies behind these, such as pathologic lesions, cancers, trauma, infectious diseases and congenital defects. Initially, the goal of reconstruction used to be mainly the functional rehabilitation that involved the tandem TMJ action and maximum mouth opening, as well as the aesthetic function that involved symmetry, chin height and other normal features. But recently the goalpost has shifted further. Now the dental rehabilitation has become the sole motive or the ultimate motive of the maxillomandibular reconstruction, so that the function, the quality of life of that patient can be regained back to the normal. For this, we need to begin with the end in the mind, and we have to have a inverse plan, so that we already can predict what is the outcome of our surgery and how we can improvise the results as well. So this inverse planning using CAD/CAM technology is done. So this is the the surgical phase, in which we have, on the above, we have placed the patient cutting guide, patient specific cutting guide for the resection, and this is after resection, the way we see it after the resection. Now we are here harvesting the fibula graft for the same in a pre-planned manner. This is, if you can see clearly, there are triangular sections that will be not used, and the rest of the part of the fibula will be used to reconstruct the mandible in a three-dimensional manner. So, taking the reference from the pre-planned models, we can reconstruct the mandible and use mini plates for the stabilization of the same. If we are planning for the implant insertion, I told you already that this process should be done before the graft harvesting and even before the initial cut of the fibula. First place the implants and then go with the normal protocol as per the cutting guides. This is the implant inserted. This is the reconstructed area. Why I showed you this? This is also this is the case which had the implants placed immediately. Now I will show you the results of such cases also later on. Then is the prosthetic phase. See, the use of CAD/CAM does not restrict with the use of oral surgery only. We use CAD/CAM for the final fabrication of the prosthesis also. Again, the process involves data acquisition, primary diagnostic impressions, which may be manual or intraoral scanner based. Then the bite records. See, this is one of the most important steps which we generally rule out as a normal perspective, because we are like already facing a lot of trouble, so we try to bypass this step. But if the bite records are not good, the occlusion can never be stable. So the advantages of CAD/CAM planning are normal anatomic shape and contours are restored very efficiently, excellent bone-to-bone contact, faster healing and rapid recovery. Fixation is achieved by mini plates, avoiding complications associated with thicker reconstruction plates. Dental rehabilitation is easier and straightforward, and it also reduces our operative time. CAD/CAM technology has taken reconstruction to next level indeed. It has indeed enhanced significantly the predictability of complex rehabilitations, ensuring the long-term stability of the final prosthesis.
Sit down before the sensation of this, and before sit down and operate the dentist time. This is very important, the diagnosis is dental rural camp. In this moment, the Dental Council of Andhra Pradesh, only 15 dentists in August. This year going to the dentists without barriers, August 15 to August 30. I stay July and August. This is the staff, possibly stay maximum 1 year, but now it's impossible for the problems with the Dental Council, with the volunteers. We have also many projects and many different programs in this NGO. Years ago, with Vicente Ferrer, 30 years ago, and we have many friends, Ayurvedic doctors, and sending many patients with this to the lesions and the problems in the oral mouth. Vincent, please, I send you one patient because I don't care, you analyze the problem. Many times we speaking in different, you remember also, this doctor is the University of Barcelona, and this source with instruments or doctoral, I think is the future dental college. This is my promotion of medicine. Every 5 years we have a meeting in Barcelona for this NGO. Last year, the Cardinal Luis Martinez staff is in the conclave for relation to the Pope Francis I, and very interesting also in NGO. There are many children. It's very problematic, and very important for me to go with one on to pediatric. We have also 4 sisters, Catholic sisters. They are stopped for spraying the priest. It's impossible. But there are many children. And in general, 90% of the children in hereditary formation get HIV. The father, this picture is in a hospital of Kanekal, and the next is in the hospital of Batalapalli. because in Batalapali they are the girls and in Kanekal they are the boys. Very nice people, all the seropositive. One of my work is summer, go to the public schools with my assistants for speaking with the boys, you know. We're routine, we speak in the very important to routine the teeth at night. But the people is very poor. I remember in the 33rd 1 year, I speaking with the boys, very poor. Please, after breakfast, after lunch, and after dinner, you routine because it's very important. And within the family, please listen. This is not correct because many children don't have a breakfast, don't have lunch, don't have dinner. So it's usually one lunch or one dinner a day, only one. Many children, they are nurses in the rural camp. I think this picture is from Laura, you know. There are programs with prevention for the boys. This is very important. The new generations. This is our hospital in Kanekal. The 3 dentists, Indus dentists. This is the teacher, handicapped teacher, and the boys, you know, it's the same. This is Laura with the children with HIV. Every time you finish the work at 5:30 p.m. are going to the routine the teeth, very important for our explain the form, explain to the form International Congress, also very important for the new generations, the oral prevention in the children. Is very, very important for our, you know. Also we have the program for the adults, and Eugenio, está por aquí, ¿no? Eugenio, recuerdas, ¿no? A Antonio Castaño. We have so many periodontology. This is very typical in rural town. This is very normal. Periodontology, with the patients. Is the Caliandul Hospital. We don't have only one color in the composite. It's another problem. This is many pathology. This is not important in this moment. But the fluorosis, this is more typical because in the south India, in our state, in Andhra Pradesh and in Anantapur, there are many fluorosis. 90% of the patients, they have this problem. Biopsia, tumors. And we have a problem with this tumor because the aspect is not correct. We will be to the Bangalore hospital, but the contact with the Bangalore hospitals. This is the more typical for the Bethel. This is the Bethel. This is the pathology of the teeth. And the long teeth is our department. This is the operative dentistry. Many tuberculosis is started in this state, in the South India. This is not interesting. This is our in the rural camp. This is terrible. And this is my new project with the census program in the forest. In the forest, 1.5 million people in the forest. I am sleeping in the tree, over the tree. This is the life of these people. And I practice in the next year with these people, 1 gynecology women, 1 pediatric women, and me. You know, the 3 going to the forest. You know, the forest in the sea. Very interesting people want to live all the things. You know, because we have many patients, and this is very important to attend this function. And dental volunteers only speaking. A very nice man, Carlos Novera, you know, in our faculty in Barcelona. The volunteers of my team, this is the 3 from Barcelona students that graduate, volunteers in the team, and working too much. This is the my patient is the Minister, Sunita Patiala, is the Minister of the Environment in this moment. This is the Sunita Patiala, this is the home of the Sunita Patiala. Practicing in RDT, in one special Daba in South India. Also we have one program for hygienists, possible. But in the weekend, we are party, tourists, etc. With this last picture, with the Quechua, it's a very nice boy, handicapped, because the fathers don't like this boy and put him also in the container. And we recuperate this boy, and it's a very nice boy. This is with handicapped children. It's in my campus in the hospital, you know. And after many projects, many humanitarian projects. In Andhra Pradesh is the very poor people, and in Tapur is very poor people, you know. Well, this is my speech. Thank you so much. And hope it's very interesting for me. For you, I don't know. Thank you so much.